This episode is brought to you by Neurocrine Biosciences. Thank you, Neurocrine, for helping NADF continue to educate, bring about awareness, and save lives. Welcome to All Things Adrenal. Each episode, we'll hear stories from individuals living with adrenal disease, share updates on treatments, research, protocols, interview medical professionals, and explore all things adrenal together. I'm your host, Vanessa O'Rourke, NADF Community Engagement Manager and fellow adrenal warrior. Today, we are joined by Dr. Elizabeth Regan, a patient, a medical professional, and a fierce advocate. Dr. Regan is a physician researcher in Colorado who is interested in improving diagnosis and care for people affected by adrenal disease, particularly adrenal insufficiency. She is developing a research focused on patient registry that will collect information about people with various forms of adrenal insufficiency. Her goal is to encourage other researchers to use the registry for research projects to improve drug improvement, treatment options, and look for prevention strategies. She recently published a paper identifying difficulties with the emergency injections that was published in Endocrine Practice. When Dr. Regan isn't researching or working, she is very active in the outdoors, biking, swimming, hiking, and skiing. With that, it's my absolute pleasure to welcome Dr. Regan.
Good morning, Vanessa. It's wonderful to be here with you, and I'm looking forward to our conversation.
Thank you so much for taking the time and energy. I know so many people are going to be very excited about this conversation. So with that, let's just dive right in. Why don't you share what your particular connection to adrenal disease is for those that don't know?
I was diagnosed with adrenal insufficiency in 2016. And that was a life-changing diagnosis for me, as it is, I think, for many of us. And at that time, I was a physician researcher and talked with several different endocrinologists, fired a couple, and realized that the level of knowledge about adrenal insufficiency was far below what I've seen in other areas of medical care. It appeared that it was a lost soul in some sense, that was not being researched. And I decided that I had skills from my research career that I could leverage to try to get more and better information about the disease, with the hope that we'd have better treatments, because I don't think our current treatment strategies are great.
I agree, and I know we're not alone in that thought.
Yep.
Okay, so you're diagnosed with adrenal insufficiency. You have this researcher, professional, all this knowledge background. How did the MyAI study really, come to life? And what is let's go back on that. Sorry. What is the MyAI study itself?
My first goal in terms of trying to address the problems in adrenal insufficiency was to go and talk with people. So I went to the Endocrine Society meeting down in Orlando and was excited to meet and talk with adrenal researchers. As a physician and a researcher, I could kind of sneak in and ask questions and say, why is this so difficult? And what I learned was that people have beliefs about adrenal insufficiency that had created a total blockade of research. There'd been no research going on in the U.S. over the last 20 years that involved patients and their disease. There's lots of basic science research that's done in the U.S. around adrenal diseases, which is wonderful. But for patient care, there wasn't much happening. And so the first and foremost thing was everybody said, well, it's such a rare disease, there are no patients to study. And so I said, oh yeah? Watch me. We're going to create a patient registry and pull the community together so that we have patients that we can use for research. And that became the MyAI registry. We had to pick a name for it. And so a patient registry is simply an accumulation of people's names and contact information that say, I want to be part of understanding this disease. They share information about, in our registry, about how they got here, what their diagnostic journey was, what their current health status is. And we contact people every 6 months to say, hey, how are you doing? Have you had an adrenal crisis? Have you been hospitalized? So it's also a longitudinal research study in addition to being a patient registry. It allows us to go beyond that blockade and say, no, we have patients. And it's been an exciting journey because the patients have stepped up so wonderfully over the last, we started the registry in 2019. And at that point, I was hoping for a couple of hundred people to join. Well, we were at 1,000 this past fall. And I know there are a lot more people who want to join. And we need that many more people. Getting a lot of people involved allows us to do better research, better science, and also go to funding agencies and say, we have the ability to study this disease because we have patients who will participate.
There's so many incredible things that you just shared, and I want to backpedal for 1 second and just emphasize that, you're diagnosed, you have these skills, you have the knowledge, you became this incredible patient fly on a wall in this environment, in this world, allowing you to do hands-on research in that environment amongst those other medical professionals, realizing what is missing, and then you created it, which is just, first of all, a million applause to you. I want to commend you for doing that, creating that. I also just want to say really quick, for those that don't know, MyAI, AI stands for adrenal insufficiency. This was prior to the AI mega boom in our vocabulary in our world. So that's what AI means in our community. And that's why the study is called that, My Adrenal Insufficiency. You've created this incredible thing. There's clearly tons of people who want to join, who've been joined, who's participated. But who is eligible for this study exactly?
Yeah. It really is anybody who has the diagnosis of adrenal insufficiency, or we welcome the kind of supporting or supplemental group of people who are at risk of adrenal insufficiency. So one of the key things that people may or may not be aware of is some people just slam right into the diagnosis. They've been perfectly healthy, and then in 2 weeks, all of a sudden, they're in desperate shape. However, there are a lot of people who have a long, slow approach to the disease, what we call a prodrome. And that could be 10 years of gradually declining cortisol secretion. And that leads to low-level symptoms, increasing symptoms, and then finally a diagnosis. So that's a long discussion to say we want to include people who maybe have not yet had a formal diagnosis, but have symptoms, or they are a family member of somebody who has adrenal insufficiency. They know that they've got some genetic background that might put them at risk. So basically, we are open to anybody who wants to join, wants to sign the consent form and provide information. After they do that, then we try to determine what's the right group for them to be in. And we do that using their reports of what happened to them. And we also do that using medical records when they are able to provide those. It's a multi-layered registry in some sense, where we have people who are absolutely clear-cut adrenal insufficiency and other people for whom it's ambiguous. And frankly, Vanessa, what's been really interesting for me is to realize that the diagnosis of adrenal insufficiency can be quite difficult and ambiguous. And so people are often dealing with physicians and frustrated because they're not being told, yes, you have it. And they say, but I'm sick. and they are sick. I mean, as a physician, I mean, we have to. I find that it's problematic when you say to somebody, "You don't have this disease," because I am not the deity. I can't see everything as a physician, and I don't know. And there's a certain arrogance in saying, "I know for absolute fact that you don't have this." What's wiser is to say, "I don't see the evidence right now, but you obviously are struggling, and let's keep watching you and reevaluate you." I think that's a much better thing for both the physician and the patient. But, I have my wishes.
That sentence I'm going to try to repeat because it is probably the most valuable, wonderful sentence I've ever heard. And I want every medical professional to not only hear it, but feel empowered to use it. I don't see the evidence that you have it, but let's continue to watch you and monitor. Something, right? Go rewind and listen to what she said because it was much more articulate. But that was very profound. And I almost got goosebumps when you said that, because if more doctors just said that and acknowledged, ooh, I don't see it, but let's pay attention, lives could be saved, literally. And that's, not just adrenal insufficiency. That's medical conditions all across the field. There's a lot that we don't know. And sometimes things aren't picked up the way that we want to in labs and bloods and imaging and all of those tools. And it's time. It takes time to see that unfold.
Yeah, I totally have always felt that it's important to recognize the limitations of our knowledge and have a bit of humility, about what I'm able to tell you. Good doctors, I'm going to argue across the board, are very aware of this. I've run into wonderful physicians who taught me that lesson along the way too. So
my favorite doctor that I have is not an expert in any way, shape, or form on any of my medical conditions. But I remember when I was first diagnosed, she was like, "Oh, I don't know anything about that disease, but let's figure it out together." And I was like, "Oh," I got so excited. I was like, "Yes, let's do this together. I don't want to do this alone. I don't know what I'm doing."
Yep.
Okay, so the great thing, I'm a part of many studies and with all my medical stuff, and I do a lot of surveys, but my favorite thing about your study is that its primary focus is the patient experience. And I just want to ask, you had your personal experience, you knew what was going on or not going on currently in the medical world. What made you want to focus, and how did you decide that and make that happen, that you wanted to focus on the patient experience?
Well, when I looked at the published literature, I saw what we call in research a knowledge gap, that people have done a lot of good work, particularly in Europe, trying to understand adrenal insufficiency, but they did not connect it to people's symptomatology. And it was an obvious gap in my mind. You can't really talk about disease unless you talk to the patient and say, "Tell me about your symptoms." And when I had my own personal journeys through medical care on this, it became obvious to me that symptoms that I was experiencing were denied by physicians. I was told, "No, that's not part of adrenal insufficiency." And I was able to still go to the medical literature, find publications that said, yeah, actually, cognitive dysfunction is part of the disease. So we have this gap of knowledge in many of our frontline endocrinologists who don't actually know well what's going on, because you have to hunt the medical literature to find this information. It's not laid out there for you. Then the other reason I focused on symptoms is it became obvious to me, again, as a patient, that my symptoms waxed and waned over the course of a 24-hour day. Well, that was not talked about and still isn't talked about in the endocrinology world. I do think that there's a dim awareness of it, but the guiding voices don't acknowledge it. And so patients are left saying, I feel really crummy at 11 o'clock in the morning or 2:30 in the afternoon. And it seems to me that it's related to my dosing. That we need to understand that better. And the only way we can do that is to have people talk about their symptomatology. So that's why there's a lot of focus on that in the registry. I have to be honest, in the new iteration of the registry, I am deleting a lot of those very detailed symptom questions because we asked those of more than 1,000 people. We have the information. I don't need to ask another 2,000 people those same questions. We got enough on that. And those questions they take a long time. They create a burden on our people who are enrolling. So I've tried to really streamline the registry and focus on the questions that we think, based on previous reports, are the important ones to look at.
I think that being someone who's taking the surveys, I definitely think that you do that and have done that and continue to do that, and I really appreciate it. But speaking of that, how exactly is the data collected? I know you talked about sending a thing out, but maybe you could break that down a little bit more. Like, how is it collected through the registry, and how is that used in research, or how will it be used in research?
Yeah, so we're using very standard methodology for clinical research. We are a purely online registry. So some research, you go into a clinical center, you fill out paper forms. Our registry, we can enroll people all over the world, and we do. But the focus in my mind for this particular registry has been on the United States because nobody had done the United States before. So people click on a link that takes them to a website, and that website is the registry. The registry is an electronic process where you review and sign a consent form to be part of the registry, and then you get led into a series of different surveys where you answer questions. All of the data gets downloaded into a data collection structure called REDCap. It's used in every research university, I think, in the country. It's a very powerful data collection system. And then the data is stored. It was previously stored at my primary institution, National Jewish in Denver, but we are moving it to a new research institute also in Colorado. But both places have very high-level data security because they do this kind of research work all the time for big studies, small studies, but it's solid, high-quality research methodology is what we're using. So then once the data is downloaded within REDCap, I can, as the principal investigator, I have access to the data, and I can go in and say, give me a data set, REDCap, and then I can analyze that data and produce graphs or manuscripts. And if I have a colleague researcher who wants to do a study using the data, I can share what's called a de-identified data set. So that means that I share data, but it's coded with a number to protect the privacy of the individual who has enrolled in the study. So there are two ways, at least, for the data to be used. One is for me as the principal investigator. The other is through data sharing.
I get this visual, which I love, is, that you personally are a detective and you're solving like your own mystery or your own crime, which I really love because you have the knowledge and the skill, but you also have the condition, which I think is a very unique and incredible perspective. So I'm very glad to have you running this ship.
Yeah, that's a fun insight, Vanessa, because it's true.
Yeah.
As a physician and researcher, I have huge curiosity about the why. And yeah, for something that I can ask questions that sit in my mind, why is it older or younger people? Why is it somebody a man versus a woman. There are those basic demographics, and then there's other questions. A comorbid illnesses. How does that impact things? It's a lot of fun. It's a lot of satisfaction too.
Well, and I love, from a patient perspective, I love that this registry and that this is online because, I have almost been involved in ones that require travel, but due to my condition, the day I'm supposed to get on the plane, I wasn't able to. And then I felt, then comes that guilt of like, oh, woe is me and I can't help. And I wanted to help our community do these things. And now I'm not able to. But here with this study, I can do it when I'm having a bed day stuck in bed and I can fill it out and feel like I'm contributing and helping and making a difference, which I really appreciate the accessibility of it.
Yeah. And I'm so glad you do. Yeah.
Okay. So then you have the data, you can sift through it in these ways. How will it benefit people living with adrenal conditions in the future?
This is the hard thing about science and research is there often isn't an immediate direct benefit to the people who participate. It's a generous gift from people who participate in research. Over the long haul, it is our best and somewhat only hope of making progress. And I think I kind of hold that as a goal for our community to say, it may take us years, decades, generations to make progress on this, but we can do that as long as we start. It's like you're never going to win the Powerball if you don't buy a ticket. And we're never going to make progress on this research unless we get into it and do it. My biggest fear is that I personally don't have enough time left in my life to tackle all these problems. So again, one of the things that's really important to me is engaging other people who care about adrenal insufficiency and will move the research forward over time as well. It's got to be a long-term effort and a lot of people involved. And it's really important for us to not get caught into, well, this is my research. I believe in open research. This has been part of the world I've lived in for 20 plus years is you share your data. You tell people what you're doing. You don't close it away and hide it. You get it out there and say, this is what I found out. Can you do more? What's the next step? How do we move it forward? And most importantly, how do we engage funding people? Mm-hmm. The NIH, PCORI, other foundations, how do we get them to support the research? Because research is really expensive. The other research that I work on routinely, we have millions of dollars in funding to do the work that we're doing. That's what you need to really make the forward progress. We can do a lot. I'm not saying that we're stuck, but we have to have a foundation of knowledge in order to write grant proposals and be successful. And so we're working on those basic preliminary steps now and getting information so that we can do more in the future.
I think everything that you just said is so important to remember and hear. And for those that don't know, or for those people who are healthy, maybe you have a family member or something who's impacted by an adrenal disease. I don't think people really understand that it's not just like you get sick, you go to a doctor, you get medication, your life is better. A lot of medical conditions, a lot of adrenal conditions are so under-researched, so understudied, so misunderstood that it's like try this, buy. And then, like you said, we need to pave the way for the future to help the next generation of people with adrenal disease. But it costs money. It costs money to do that. It's not like we can just be like, well, let's just study it. We have the people, we have the medical professionals, we have you to collect the data and do something with it. But, there's more pieces to the puzzle. And as a community, I think we need to continue, because we're all doing as much as we possibly can, obviously, continue to bring about awareness and communicate and have these discussions and share them, because we need every single piece of the puzzle. We need every single player on the team in order to truly make significant progress.
Yeah. Can I share one of the projects that
Please.
we're kind of working on right now as an example for what it can cost? So there's one of the problems, diabetics, you measure blood sugar. Well, and then they're good or bad. And so they have the ability to not only monitor their blood sugar, they now have infusion devices that allow them to maintain their blood sugar in a safe level and avoid complications. Diabetes has had an incredible change over the last 20 years in my knowledge of medicine, such that people don't die now in their 40s with type 1 diabetes. We're sitting back with what we had in the 1950s. So the first thing we need is a way to monitor our health status. My colleagues at Dartnet and I are putting together a research proposal to use a device that's available in the UK. It's called Eurythm, and it provides 24 hours, every 20 minutes sampling of interstitial fluid from right around your cells to say this is what your cortisol level is. And we can collect that data and understand what happens to somebody who has adrenal insufficiency, takes a dose of hydrocortisone, and then has a life. We can send them out and say, go for a hike, go shop, push yourself a little bit, or lie on the couch. Let's see what happens. This is incredibly important data, but it costs a lot of money. To get one of those devices is $10,000, and then each time we run it and collect from a single patient, it's another $2,000. We need to bring people into the clinical research center with a clinical coordinator. And so a single study visit for doing one of those monitoring events could easily be $20,000. And, if we had NIH funding, it would still be a pricey study. But we need to start gathering that information. And what we want to do is not only put that monitoring device on for cortisol, but at the same time, put a monitor for glucose, a CGM, what the diabetics use, and use one of our great little watches, that can monitor heart rate variation, step counts, how much you've been able to do for exercise for the day, and put all of that data together with a symptom report and say, this is what's going on in a person with adrenal insufficiency who has symptoms under treatment. That's a problem. When people have symptoms under treatment, we want to know why. And we don't have a vision right now of what's going on. So to my mind, this is the first and most important study we need to do in the next 6 months if we can. Yeah, I think that it's just kind of a snapshot both of how to think about the question and how much it's going to cost us to get this going. And we will. I am certain that we're going to figure out a way to get the funding to do it. But to move this forward, it's going to take all of us in the whole community, because we need people who are willing to be research subjects, who are willing to come down to Denver and wear one of those devices for 2 days and tell us about their experiences.
I couldn't agree more that this is the most important study. I also think it's the most informative and most valuable thing, because right now what's happening, we go to the doctors, every 3-6 months, every year, depending on where you are in your journey, and they take your labs and they look at it and they go, your cortisol looks fine, or this or that. And it's like, this was one day out of 365 days. We're not seeing the day-to-day impacts of physical, mental, emotional stress, and just being a human. If we had that knowledge, it's, again, I love using, the glucose monitors or a diabetic, because I think that's something a little bit more tangible that people understand. Imagine if, once again, we were back in a place where people cannot check their blood or check their levels, and they're just going into the doctor as someone with diabetes once a year to check their blood. that's pointless. I don't want to say it's pointless. It's obviously important to go to our endocrinologist and do our labs and see these things, but that information is literally a Polaroid of one day of the year. It's crazy to me.
It is crazy. And, I just want to reinforce the craziness from a physician standpoint. This is nuts. This is not appropriate medical care. Yeah. Now, do I blame the community? No, they couldn't figure out the answers. These are complex research questions. But we should not be satisfied that this is an acceptable situation. We need to do it better.
Well, so then if anyone listening has access to helping getting funding or would like to donate, this is where it needs to go. This is what we need. So reach out to your people, because that is one of the ways we can advance.
Yeah, and I think that's a really good point. Everybody in the community has different skill sets. And if there are people out there who are really good at marketing, sales, talking to politicians, talking to, communications, all of those are things that that's not my world. I can't do that. I can do research. But, tracking down funding and building kind of a war chest, we need people who can do that. And, the example I'd give you is cystic fibrosis. Cystic fibrosis was a deadly disease until a few years ago. And the Cystic Fibrosis Foundation got together, and I know because I have a family member who was on their board of directors, and they talked with the NIH. The NIH said, it's a rare disease, and we're probably never going to fund it the way you'd love to have it funded. They got together and got the money to push that research forward. Amazing. It wasn't them alone, but their support was critical. And we all struggle with fatigue and a bit maybe of apathy because of our disease, but we got to get up off the couch, push ourselves, and do this to, move it forward.
And I think that's such a good thing to emphasize is like, we do have to do the work, but also go, back to what you said, do what you can do what you excel in, use your energy, spend your spoons on what it is. And that doesn't mean every single day you have to write your legislation or like go down to the White House or whatever. It's that for us with our situation and our medical condition, when you're able to do what you can, do you have loved ones who have skills, who are healthy? Utilize them, have them be the activist or the active participant, because every single rock is the ripple effect. What is that? When you throw the pond? You know what I'm saying.
I do. Yep. Chuck that rock in there and watch the waves go off.
Please, from wherever you are on the sidelines, throw that rock in. Let's see what happens. Okay. I kind of want to go back to the study just out of pure curiosity as a patient, because I just want to know, and I don't know what you're able to share, but like, have you noticed any patterns or things that maybe surprised you since starting the study and collecting all this patient information?
Well, so the first thing that I've noticed, which was a little bit surprising, is our community breaks down into two pieces. About 25% of people who've joined the registry say, yeah, I'm doing pretty good. I'm fine on my current dosing. 75% say, I'm really not great. So that was my first surprise, is that we are different. And the why of that, I suspect, is that some people continue to secrete partial cortisol, or secrete cortisol partially. They're not, their adrenals aren't dead, their pituitary isn't totally dead, so there's still something. And that buffers them from the worst of it. But we need more specific data, because I don't know whether those people truly are better because they are secreting or not. I haven't been able to measure their cortisol levels at 7 a.m. So we did start a study where we're collecting salivary cortisol and from people in the registry. And so I'm hoping that as we continue that collection, we'll be able to find the answer to that question within the registry. Right now, we don't know, but we have a suspicion, and that's called a scientific hypothesis. We have a hypothesis. We're going to test the hypothesis. That is, and I kind of maybe have lost track of your question a little bit, but to me, that was one of the most important findings for me from the study. Dr. Greg Kinney, who works with me from CU Anschutz, did a really interesting study of the symptoms that people reported prior to diagnosis, and he presented that this past Endocrine Society meeting in San Francisco. And what he found was that it matters what symptoms you present to your doctor for how likely you are to get diagnosed. So doctors have kind of a vision in their head of what adrenal insufficiency looks like based on what they were told in medical school. It's a pretty limited description. It's basically fatigue, skin darkening, I think nausea was one, and muscle. So we call that a classic diagnosis. And the more that people deviate from the classic symptomatology, the less likely they are to be diagnosed in a timely fashion. So it doesn't really tell us so much about who we are because we present with our symptoms. That's the disease that presents. But the interpretation of that by the doctors is a challenge for us to help them understand the disease better. And again, this is where I think it's important for me and other people that I'm working with to write papers and publish manuscripts to tell the world. You know, a lot of people say, oh, well, we have to change what's taught in medical school. No, that's really not where the locus sits. It is and it isn't, because what's taught in medical school has been filtered down from what people were taught by their mentors 20, 30 years ago, and what the current research is that may or may not filter to them. It's a very imperfect world trying to change doctor knowledge and information, but it starts with publications in the medical literature. Mm-hmm. And so that's a really important focus for us.
When you're talking about changing or adjusting something across the entire world, essentially, like, how do you get everyone on board with that? And how do you get everyone to agree? And everyone, that seems like such an impossible task, but just like you're saying, like writing papers, creating research, having more information, so that way there can be a conversation. These communities can connect and go, maybe we need to update this. Maybe, then things can start rolling in the right direction, hopefully.
Yeah. And, so we have a paper we submitted to two very high-end journals, New England Journal of Medicine and JAMA. And so far both journals have rejected it, but it's an important paper. It's talking about adrenal crisis and how you define it. Mm-hmm. And the lack of a definition is killing us, because people present to the ER and the ER says, well, you don't have an adrenal crisis. Your blood pressure, you're not in shock. You're not dead yet. Well, we need to have people getting care long before they're dead. It's not helpful to wait till the end stage. So we've written this paper. I think it's a pretty good paper, but nobody cares is the bottom line. So again, this is where the community needs to start speaking up. You need to have, our world is driven by social media, and it is amazingly powerful if it's invoked. So how do we invoke social media effectively to change people's thinking? So instead of saying adrenal crisis, nobody cares about that. I want journal editors to say, oh, that's an important area for us to publish. We need to get this out. And that happens at the level of social media, whether people believe it or not. I'm pretty sure. You look at what ALS did, with their ice bucket thing. You can change people's thinking about diseases and what's important. So again, this is why I was saying we need people who know marketing. We need people who know social media to get out there and do it. And do it not just in our community, which I think we do well in our community, but how do we spread it out and make it a bigger story? I don't know, but I hope there are people who do know how.
And if you do, reach out to us, reach out to all of our community, or, share your stories. That's how I started with NADF, is I just created a YouTube channel. I didn't know what was going on. I didn't know what was happening, but I just started talking into a void because I didn't, this was a long time ago, pre-social media chaos, but I didn't see anything. I didn't know anything. So the only way I felt like I could contribute was just talking about what was happening to me. So whatever that version is for you and your skill set, that's the call to action, I guess.
It is absolutely the call to action, Vanessa, and I'm so glad you spoke into the void.
I know, it feels like 100 years ago now. Okay, so I want to honor your time and energy. Obviously, all the information you've shared is so valuable, and there's so much more we can unpack. And actually, before I ask my last question, for those that want to learn more too, we actually had our first inaugural Navigating Adrenal, disease in general, and adrenal conditions conference in October. And we have a presentation that Dr. Regan did on this, and that you can watch and learn more about, and more information as well. But that's on our website at nadf.us under videos. You can watch that to get a full presentation about a few of the things that are going on. Is there anything else that you would like to share about the study, or maybe just about adrenal disease in general? I know we've covered a lot of things, but any final buttons that you want to put out there?
I think that we've covered so much, Vanessa. I'm kind of good with what we've
We're tapped out.
Yeah, and I hope, as time goes on, maybe at an interval there'll be more for me to tell people, and we can talk again. But I think we've done a lot for the morning.
I couldn't agree more. Thank you so much for being here and for all the hard work you're doing. I cannot imagine, again, these are not my skill sets to do research and be so educated like you are, but I am so grateful that you are utilizing your skills to help make a difference for our community, for our future, and for all those impacted by adrenal disease, because you are doing the work that's going to save so many lives.
Thanks.
Thanks for being here, Adrenal Warriors. I'm your host, Vanessa O'Rourke, sending you all the spoons, and I hope you have a wonderful day. Thanks for joining in on another episode of All Things Adrenal. This episode is edited and produced by Magdalene Zinke. For more information on the National Adrenal Diseases Foundation, please visit nadf.us. If you're listening on Spotify or Apple Podcasts, please leave us a rating and review to help others find out about all things adrenal. If you have a story you want to share or a question you'd like answered, reach out to NADF support at nadf.us.